Our first speaker is Dr. Patrick Bennett. Dr. Bennett has been practicing urology in Marin for 22 years. He sees patients with a broad range of urologic conditions, including cancer, pediatrics, and stone disease, but he has a special interest in fertility, sexual dysfunction, and the urologic impact of low testosterone. So this evening, Patrick is going to provide an update on current trends in the treatment of erectile dysfunction, Peyronie's disease, and premature ejaculation. Patrick.
Thank you, Eric, and thank you all. Thank you for teaching me how to use this. Can you hear me okay now? Is this good? Thank you, Eric, and thank you for coming out this evening. It's really a pleasure to be here with Eric and my colleagues with whom I work every day. These diseases or these conditions we're talking about really do require a team approach, and we have an excellent team of my colleagues in my office and these fellows and the colleagues in their practices as well. I'm just going to really give a kind of a high-level overview of common conditions that we see in our practice and that we'll be focusing on in the Men's Health Center that is opening up imminently just downstairs from where the main urology office is. And just to give you a brief sense of these conditions, their prevalence, and how we're approaching these conditions today. So the first topic, which really was spoken in hushed tones until the development of Viagra, Sildenafil, a number of years ago. This was something that, was not, certainly wasn't something that would be advertised in the Independent Journal 20 years ago, or 40 years ago when I was a paper boy in San Rafael, but now is sort of the topic of conversation on the bus, or in certainly these medications that have come out have really thrown this condition into the public sphere, and it turns out that this disease is a bit of a marker for other diseases, whether they be cardiovascular disease or endocrinologic disease. Other sorts of problems often show up with, or often become apparent because a patient strolls into my office or his primary care office, practitioner's office, and says, hey, I'm having a hard time with erections. How do we define it? Very simply, the inability to maintain an erection sufficient for satisfying sexual activity. That really takes a broad range of sexual function in, but the patients come in and they describe really all urologic and symptoms. The question is, does it bother you? And patients may define their dysfunction differently. What's the incidence? Well, no surprise, it's age dependent. There are cases of young folks who come in to see me. I occasionally see a college student who comes back. Their idea of erectile dysfunction is different than that of a fellow who comes in after 70 years of age, something like that. But as folks get older, it becomes more prevalent, in part because of the cardiovascular risk factors, in part because of medications. Essentially, all of the things that we'll see on the next slide that can cause this become more prevalent as folks get older. So when we look at the causes of erectile dysfunction, the huge majority of them here are vasculogenic. And these are diseases that Dr. Keefe will touch upon as he discusses the connection between cardiovascular disease and erectile dysfunction. Big issue here, pharmacologic. Many of the medications that we use can affect erectile function. Operative treatment for prostate cancer, for example, is associated with a very high rate of erectile dysfunction. Endocrinologic, neurologic, and trauma. Now, when I was in my training years ago, there was a very big emphasis on finding out what the exact cause was. It was considered something like abdominal pain. If you did enough tests, you'd figure out whether this was, the gallbladder or the appendix or the colon or something. Erectile dysfunction was treated the same way. We thought, well, patient comes in, we'll figure out whether it's a neurologic issue or an endocrinologic or a vascular issue. Was it their medication? And over time, it became clear that it was usually a combination of all of these. That as folks get older, there's often a little bit of everything. And then layer on top of all of these, psychological, because once a fellow has had one difficult experience, and certainly two or more, once they've had a bad experience or a challenging experience, maybe a new partner, the psychological overlays there. And I often use this, now I'm going to set this down, just causing trouble. I talk about, how a great pitcher from one year wins the Cy Young, and the next year is having a hard time throwing strikes. Yeah, a year older, maybe physiology is a little bit different, but often there's a psychological component that affects how well one pitches and how well one performs in the sexual realm. So multifactorial, it's helpful to sort of enumerate what those risk factors might be for a patient, in part because you could identify some of them and treat them specifically, but in part because they're markers for other diseases. So when a patient comes in to see me, if he hasn't had a comprehensive evaluation and it seems as though he might be at risk for heart disease or vascular disease or a neurologic condition, that's a tip-off that maybe he needs further evaluation by some of my colleagues. So treatments, just to keep moving quickly here, address the underlying causes. Obviously, over the last 20 years, we've had the oral medications, Viagra, Cialis, etc. These, again, have been game changers. How do they work? This is, by the way, this is referring to the penile prosthesis, but let's go back for a minute to the cylinders that you have short of surgery. With arousal, the blood vessels receive a signal through the nerves to dilate. Well, the way we're built in many of the systems in our body, when there's a stimulus to dilate, there's also a counter braking mechanism, a stimulus to constrict those blood vessels. And it's this balance that runs most of our functions. In a fellow with erectile dysfunction, that braking mechanism trying to constrict the vessels that are otherwise getting a stimulus to dilate, that braking mechanism may be just too much and they don't get a good erection. If they take the oral medications, those oral medications interfere with the braking mechanism. It's taking off the brake so that with arousal, the stimulus to dilate the vessels is now adequate to give a good erection. So patients sometimes wonder, if I take that pill, will I just get a spontaneous erection? And the answer is no, because it takes the stimulus, it takes the accelerator being pushed down to really see the benefit of the pills. Are they safe? They're very safe. We could go into potential complications, but really they're dangerous almost only in the context of a patient taking nitroglycerin-containing heart compounds. Otherwise, they tend to be very, very safe. In fact, they were developed by cardiologists looking to treat heart disease, and it turned out not to do so much on that score. For patients who don't respond to pills, in my practice, we'll talk about injection therapy. Frightening thought for most men, using a needle to achieve an erection, but it's very effective. And once fellows learn to do it, it's not unlike fellows who learn to use contact lenses. Sounds scary to put a piece of plastic in your eye, but once you've learned to do it, patients do very well with contact lenses. Similarly, with injection therapy, a couple of sessions of learning how to do that from our staff, and they're off to the races. There's a vacuum erection device called penis pump, and then there's the penile prosthesis surgery. In my practice, I find that the most important question to ferret out to see if someone is a great candidate for this is, what does your partner think? Is your partner enthusiastic? Is your partner interested in you undergoing a major operation to achieve erections? Because it's going to be a lot happier if this is kind of a team approach to solving the problem. So Peyronie's disease, let me talk about this briefly. Not a very common disease, certainly not rare, 1 in 200 men get this, but it's a scar tissue that forms on one of those cylinders that fills during an erection, and as this scar tissue develops, it inhibits the stretching of that corporal body. So if you get scar tissue here, this doesn't stretch, the other side does, and it bends around. The reason I'm bringing this up is that there is now advertised in many places a new treatment for this. For years, doctors looked for medical treatment, injection therapy, radiation, surgery to correct this problem, and were quite frustrated that things didn't, nothing really works very well. There's now a new medication called Xiaflex, which can be injected into here, and it actually dissolves the scar tissue. Has some risks and can injure the penis. It can be somewhat uncomfortable, but it offers now men who have a severe case of Peyronie's disease a good opportunity to get better. For years, it was wondered, what was the cause of this condition, and it seems that it's bending of the penis, an injury that might occur during sexual activity with a penis that's not entirely rigid, such that a patient might be at more risk of bending and I want to thank the head of PR for putting in the giant sequoias over there. I think most of us would be happy with just one, but having a forest is, yeah, but I'll let Jamie know that over ambitious for us. But observation, most men with curvature of the penis I see, it's not a progressive condition in the vast majority of men. So for most of the fellows who come in, I say, look, this is the new you. Avoid intercourse when it's tender, if it is tender, and learn to accommodate it, and most patients are very happy with that. Anti-inflammatories may be helpful when it's uncomfortable. Oral medication, thousands of different types of medications have been tried. None of them really do much for patients, although there's questions about some medication. It's a complicated landscape, but really oral medications are not so promising. But this new thing, Xiaflex, the injection, is very promising. Just going to end up here with another very, very common problem in our practices. And if erectile dysfunction becomes more common as men get older, this is a condition that I see very, very frequently in young men. And it may in fact be somewhat related perhaps to the availability of pornography, and how is that affecting the kind of the sexual development and maturation of adolescence and early adulthood. But in any event, it's defined as the inability to delay climax long enough for a man and his partner to enjoy satisfying sexual activity. It was always called, or many times it's still called, premature ejaculation. The terminology in our professional society is now early ejaculation, so changing the terminology to perhaps remove a stigma. Could affect as many as 30% of men. There are some fellows and some couples perhaps who don't even realize that things could be better than they are. Historically, it was defined as climax within 3 minutes. Others have defined it as climax within 1 minute. I have patients who achieve climax even before vaginal penetration. So depending on how it's defined, how it's reported, the incidence does seem to be quite high. Quickly now, the treatments, behavior modification, and sexual therapy can be very, very helpful for couples, particularly those individuals or couples together that really don't have a lot of insight into how they might please each other and so on. And I work with a number of therapists who specialize in this. Secondly, there's a group of topical anesthetics just to reduce, much like using a condom, or topical anesthetics that just sort of reduce sensation. But the big thing is that SSRI antidepressants, the Prozac, Zoloft, that whole Paxil, those medications have done a great deal for patients with depression, and it was found incidentally that they, in men and women, delay or defer or make it more difficult to achieve climax. Now, that can be a big complication, or in the case of men with early ejaculation, a benefit. So we now use these SSRI antidepressants quite effectively for men with this condition. Well, that's, I hope I didn't go too far over. There you
go. Dr. Willis, Matt Willis, who is our next speaker, is going to talk about a topic of how men access healthcare. So he is an epidemiologist, and let me just describe Dr. Willis's background. Matt Willis is a Marin native. Dr. Matt Willis has been the county's public health officer since 2013. Dr. Willis calls on experience as a primary care physician and an epidemiologist to guide public health strategy for Marin County. He is a champion for data-driven and highly collaborative approaches to complex public health challenges. Prior to his role in Marin, he served in the U.S. Public Health Service as the Director of Primary Care on the Navajo Reservation and the Centers for Disease Control in Atlanta, conducting outbreak investigations in the U.S. and abroad. He has published research in tuberculosis control, disaster response, and the opioid epidemic. He holds a medical degree from Temple and completed a master's in public health and internal medicine residency at Harvard. Matt lives in Marin with his wife and his 3 children, and again, he's going to talk about the approach that men take when they're accessing healthcare, and he's going to talk about some of the epidemiology. Matt.
Thank you. You know, as I was honored to be asked to be a part of this forum, and I have to say that among the things that we're prioritizing in Marin County, men's health per se has not been the top of the list, and I think that's probably emblematic of some of the experience of others. And I was reflecting on what is the specific advantage of taking sort of a gender-specific view on healthcare, we clearly know that for women's health, there's a lot of specific issues that women face that justify the importance of women's health care and women's health facilities and clinics. Less so for men. But in this course of doing some research for this presentations, I've come to the conclusion that there really is an important and specific value to a forum or a location dedicated to men's health. And the question is, what are those features of men sort of across the board on a population level that would justify or indicate the need for a men's health specific clinic? And so I started by looking at some of the data on gender differences in healthcare status, and found a study that was published in 2014 that was conducted, a survey that was conducted by Kaiser, coming into the Affordable Care Act in 2013. Interestingly, this study was actually designed to determine what women's health needs were, but in order to do that, they needed to stratify the results by gender, so they ended up with a cohort of men and a cohort of women, and then in a secondary analysis, we were able to actually describe men's health more specifically, and I'm going to summarize some of those findings. So this is the Kaiser Family Foundation. They were looking at issues of coverage, access to care, connections, personal connections to providers, and the use of preventive care services for men. Nationally representative sample of men aged 18 to 64 and women. About 3,000 women, about 700 men in the study. And I'm just going to go through, quickly go through the findings and then relate them to what we see in terms of men's health outcomes in Marin County based on our own data. So we know that men are less likely than women to have seen a provider. In this study, men were less likely than women to have seen a provider in the past 2 years. So about 91% of the women surveyed had seen someone in the past 2 years, whereas about only 75% of the men had. And then they stratified by socioeconomic status. And I won't go into those details around the socioeconomic status. And those will be, throughout these results. We'll be focusing on total men and total women. So fewer men than women had said that they had a place to go when they felt sick or had needed medical advice. So that idea of like a relationship with, this is my doctor, this is where I go for care, this is where I would go to when I had a question. Fewer men actually were able to endorse that they had that kind of relationship. 86% of women said they knew where they would go, only 72% of men. Men were taking fewer prescription medications. 63% of the men in the survey, again, these are men aged 18 to 64, had no prescription use at all, whereas only 44% of the women said they were not taking any prescription medications. And then screening. So, obviously as a correlate to less care and less access to care, you might expect fewer medications and also fewer opportunities to receive important health screenings. So compared to women, men had fewer occasions of a general checkup, had fewer occasions where their blood pressure had been checked just as a routine screen, and fewer occasions where their blood cholesterol was checked. So fewer visits, fewer kind of my doctor kind of relationships, fewer prescription medications, and fewer preventive screenings. So is that just, does that mean that men are healthier? And unfortunately, when we look to the question is, what is the health status of men versus women relative to these health-seeking behaviors? And I think it's not a surprise to most of you to know that life expectancy for men is shorter than it is for women. And I looked at the data for Marin, and we looked at the 6 leading causes of death overall for all people. So the highest mortality rates. So heart disease, and it's flipped, sorry, the bottom is the highest. So heart disease, cancers, malignant neoplasms, cerebrovascular disease, so stroke, chronic lower respiratory diseases, and accidents, and Alzheimer's. These are the top 6 causes, overall causes of death in Marin County. And for all of them, the death rate is higher for men. And importantly, significantly higher for the leading cause of death, which is heart disease. We all know that men are at higher risk of cardiovascular disease, but it adds some acuity to it when we really see it at the local level, especially when we combine it with the observation that men are getting fewer screenings, even for blood pressure and cholesterol.
What is the the totals, like on the bottom there, heart disease for men, is that 248 per 10,000?
248 per 100,000 per year. So these are mortality rates, yeah. And it's just a way of standardizing comparative analyses. It's hard to translate that into that. I have the actual numbers somewhere else, but I don't know those off the top of my head. So to summarize those findings, men in Marin had higher mortality rates in all 15 leading causes of mortality, 35% higher risk for heart disease death, 29% higher risk for cancer death, 42% higher risk for accidents, so motor vehicle accidents, that kind of thing. And then importantly, 41% higher risk for suicide. When we look at our suicide rates in the county, and this is something we've been doing as a separate initiative, it is alarming to see just that there's such a stark gender differential. Obviously, it's tragic each and every time, but there does seem to be a sort of a particular issue around men's sense of willingness to engage in support and healthcare and mental health if they're feeling like the world might be better off without them. So that's sort of my point. Here's the typical men's health visit. You probably should have come in a little earlier. So in conclusion, and I think it relates to this question that Patrick was referring to, healthcare providers in all specialties should recognize that any touch with a man is an opportunity for health promotion. So, sadly, I think the stereotype, and I think, in my own life, it's you wait till you don't feel well. I'm not getting in every year for my routine visits because I feel okay, right? I'm fine. But in fact, if there's something that brings a man in to healthcare through any door, and sometimes erectile dysfunction might be one of those early signals there's an opportunity there to take advantage of that encounter to actually maybe have a more holistic approach to that person and recognize they may be at risk of undiagnosed cardiovascular disease or even mental issues. So touches may be few and far between, should reward the impulse to reach out, both acknowledging physical and mental health. And importantly, I think all men should see themselves as being a part of a community that supports health, family, friends, and healthcare systems. Men are called the weaker sex. And I think this data suggests to me that if we are the weaker sex, it's partly a weakness of strength, right? It's a perception of what we perceive as strength, which is independence, not needing other people. And maybe we would be stronger if we were more honest about those areas where we're not feeling as strong. So messages of self-care are vital for us across all aspects of healthcare in the community. Thank you.
All right, excellent. So we heard from Dr. Bennett about some common illnesses that are likely to bring a man in to see the doctor, and then we heard the messages from Dr. Willis about the fact that men are less likely to go to their routine screenings than women are, and there's a high prevalence of disease, particularly cardiovascular disease amongst men. So that's a perfect setup for our next speaker, who is Dr. Brian Keefe. Dr. Keefe is a native of Portland, Oregon, and has been practicing cardiology here in Marin for 15 years. Dr. Keefe received his undergraduate and medical school training at Georgetown University, his internal medicine training at Stanford, and his cardiology fellowship training at the University of Washington. He's an avid cyclist and runner, and he has developed a fascination with cardiovascular physiology. Dr. Keefe is a strong believer in the use of diet and exercise to optimize cardiovascular health, and he has a special interest in sports cardiology, preventive cardiology, cardiac CT imaging, and the cardiovascular benefits of exercise. Dr. Keefe.
Thank you. So we've touched on a little bit of what I want to talk about, which is this kind of link with men's health, and in particular erectile dysfunction, and a way to kind of capture men, look at their heart health. I do that a lot in
when I see patients for any reason, whether it's heart palpitations, high blood pressure, shortness of breath, whatever the chief complaint is of anyone coming to see me, I always dive into what is their 10-year cardiovascular risk, what is their lifetime cardiovascular risk, and then what can we be doing about it, whether it's medicine or diet, exercise to improve it. So, I think a lot of us know what some of the risk factors are. We kind of hear about it. One that we can't do a lot about is as we get older, we're at higher risk. That, the advancing age, we can't do anything about. But, high blood pressure, high cholesterol levels, diabetes is a big one, smoking, lack of exercise, and obesity are, kind of the main things that we look at. Family history is another one that we think about, but there's not a lot any of us can do about what our genetics are. So that's, again, something that in any doctor's visit, a lot of this we can do through basically, a quick blood pressure exam, history, and a fasting blood test. As you can see, these risk factors for erectile dysfunction are quite similar. So as we're thinking about men's health, and this is a reason why a man in their 50s or 60s or 70s may not seek medical attention, but might for this, it's an opportunity to look at heart risk and cardiovascular risk. So similar risk factors: obesity, being sedentary, watching a lot of TV. I don't know exactly, Patrick, why. Screen time, as we call it in our house. It's basically not moving your body. Smoking, sleep apnea, which is another kind of risk factor in heart disease that we've recognized over the last 10 or 15 years. Cholesterol and diabetes. And this link was initially thought to be, well, the penis, as Dr. Bennett showed us, is a vascular organ, that these same plaques that we can get in our coronary arteries, our carotid arteries going up to our brain, our aorta, maybe those penile arteries are getting plaque also. But now what we think is it's actually the inner lining of the blood vessel, the endothelium. And the endothelium is really critical. It's a kind of organ that will dilate and contract, and it plays a role in heart attacks and vascular disease in general. And what we see with endothelial dysfunction is it's a state where there's an imbalance between the vasodilation, which is the relaxation, and the vasoconstricting, and there's a whole bunch of hormones and pathways which I couldn't even explain to you how that all happens, but we get this imbalance where our blood vessels, whether it's in our penis, in our coronary arteries, aren't dilating correctly or are constricting too much. And in the heart, that may cause or contribute to a myocardial infarction or a heart attack, where you get inappropriate constriction, plaque shift, clot. In the penis, it can be erectile dysfunction. So, if a patient comes to see me or if someone walks into the men's health clinic, it doesn't require a cardiologist to do a basic, cardiovascular risk assessment. It's a history and physical, including blood pressure, and then a fasting blood test, which includes cholesterol, the fasting glucose, because there's diabetes, but there's also, what we call glucose, pre-diabetes or glucose intolerance, where you're on your way towards diabetes, but some of these same processes with endothelium we can see in that condition. And then if we are suspicious based on symptoms or possibly an EKG, then we can go to the next level of heart testing, whether that's exercise testing, which I do a lot of, or some imaging tests to look for early plaque. So in Marin, we've started something just to talk about a few different programs that we have when we do recognize, cardiovascular disease. One of the things that I like to focus on is not just the medicines. Medicines definitely play a role in treatment. But a lot of what can happen, when we talked about these risk factors, is the lifestyle choices that people are making, and some of their behaviors are not optimal. So we've started something called intensive cardiac rehabilitation, and we've gone with Dean Ornish as a physician who's done a lot of work on the non-medication aspects of cardiovascular disease. So this is a program now for people who've kind of gotten to the point where they have clinical cardiovascular disease, whether it's a myocardial infarction or heart attack, bypass surgery, stenting, valve surgery. And really the 4 pillars of the program are nutrition, stress management, exercise or fitness, and social support. Again, these are all the same things that Dr. Bennett was really talking about in some of these same conditions. And it makes sense because all these things are improving the endothelial function. Okay, they're helping that. They're also helping our blood pressure, our cholesterol, our stress levels, which can contribute to everything. So this has been a wildly successful program where the people who go through it, just sing the praises of it. It's really fantastic. And as I said, or Eric was telling you in the introduction, I love exercising, I love sports, and I love getting my patients to exercise. So, because I really believe of all the things that we do, if we can get our patients to exercise, it has massive benefits: mortality prevention, diabetes prevention, cardiovascular prevention, and it's really just moving your body. So I have a big push of trying to get people to exercise, and a lot of what I do, not only do I evaluate athletes and do stress testing and figure out how they might be able to perform better, but anyone, it's the same test. We do a test to make sure that you're okay to exercise, that there's no major heart condition, but we can also take that same information and give you real physiology to help starting from the couch and getting to fit. So, and those type of things, it's my belief, you get the weight down, you get exercising, your blood pressure comes down, you feel better, your endothelial function improves. And so that's, what I hope with the men's clinic we're starting, is that we can just capture more people and, find cardiovascular risk and treat it through a lot of, medicine if needed, but more, more just lifestyle, diet, exercise, stress prevention.
All right, excellent. So this is going along quite well. So we heard from Dr. Bennett about some common illnesses that are really going to get the male patient into the clinic or in to see the doctor. Then we heard from Dr. Willis about the fact that men are less likely to, just for routine screening visits, to access health care, and yet they have this high burden of illness for cardiovascular diseases, particularly strokes and heart attacks, and the other things that Dr. Willis talked about. And then Dr. Keefe talked about his kind of holistic approach to the care of cardiovascular illness and getting patients exercising, and the link between cardiovascular disease and erectile dysfunction, which is kind of how we started, and we're kind of continuing this kind of theme of illnesses that are that men approach differently, and that men have with greater numbers than women. So our next speaker and our last speaker before we take some questions is Dr. Alex Uline. Dr. Uline is relatively new to Marin, having moved from Chicago 2 years ago. He practices general endocrinology, which includes diabetes care and thyroid illnesses and a whole host of endocrine type problems. But he has a special interest in men's health and bone metabolism. And today he's going to be talking about sort of what's called in the lay press low T or testosterone dysfunction and the use of testosterone therapy to benefit men. Dr. Uline.
I'd like to talk to you about how we think about testosterone and testosterone replacement, and specifically how we think about it in male aging. And I thought that this was an interesting way to start, because this is actually information from commercial insurance and Medicare claims in the US, and then from this big database of information in the UK, the Clinical Practice Research Data Link. in the United Kingdom looking at testosterone testing starting in 2000 and up to 2010, and then initiation of testosterone replacement. And you can see in, I don't know if this has a pointer here, in 2000 is when the testosterone gels became available. So the gels that you apply to the back of your arm made it more easy for men to start on testosterone replacement. You can see in the U.S., both in the U.S. and the U.K., soon after these became available, testing for testosterone levels became much more common, and initiation, at least in the U.S., became significantly more common. There's also a big uptick in 2008, which I think was probably when there started to be more direct-to-consumer marketing. So this has become a big issue for us in endocrine because people come in and say, I'm fatigued. Sometimes it's just I'm fatigued. Often it's I'm fatigued and my libido is low. I might need testosterone. I heard an ad on TV or on the radio that I might need testosterone. Probably one of the most striking things about this study is that they looked at the 180 days prior to testosterone initiation, prior to a claim showing that someone initiated testosterone. And 40% of those in the US didn't actually have a testosterone level drawn in the 180 days prior to initiating testosterone, and actually 54% in the UK, which surprised me. But so there's definitely, this is happening sometimes without appropriate evaluation. So start by talking about why men need testosterone. It is very important for libido, for sex drive, and for erectile function. Important also for sperm production, less important obviously in older men. Very important for bone and muscle health, which we'll touch on later on. And then red blood cell production, actually it's the reason that men have higher hemoglobin hematocrit levels, higher red blood cell counts than women do. The normal range for men is higher than it is for women. And then just male sexual characteristics as well. So I separated this out into more specific symptoms and signs of low testosterone because there's some that are much more specific than others. Decreased libido and erectile dysfunction are definitely more specific, although they're, as Dr. Bennett showed you earlier, there are a lot of reasons for erectile dysfunction and for libido. Libido is obviously, there's a lot of higher brain function that goes into your libido as well. Breast enlargement or tenderness under the nipple can be a sign of low testosterone. Low trauma fractures and height loss is probably something we ignore a lot, especially in men, and that's something that we really should be paying more attention to, not just checking testosterone, but also thinking about men's bone health and treating osteoporosis when appropriate or fragile bones. And hot flushes and decreased shaving frequency can also indicate low testosterone. And then less specific, irritability, fatigue, decreased motivation. Some men notice worsening concentration and memory. Sleep disturbances or sleep apnea, there's some disagreement in the literature about whether sleep apnea is a cause of low testosterone or whether low testosterone may worsen sleep apnea, but we'll get into that a little bit later as well. And then anemia and reduced muscle mass and strength, increased fat mass. So you don't have to focus too much on all the details of this, other than the main point here is to know that there's more that goes into regulation of testosterone than just the testes. The hypothalamus that sits at the base of the brain, right in this area, is sending a signal to the pituitary gland, which is kind of the master gland in the body, that then sends a signal called LH, luteinizing hormone, to the testicles to produce testosterone. And so when there's a deficit, when men have low testosterone, there can be a problem in any one of these locations. Sometimes it's a pituitary tumor. This is obviously pretty uncommon, but it's something we don't want to miss. So we recommend early morning testosterone measurement always, because there's a diurnal variation in testosterone where it's highest early in the morning, and then it gradually comes down throughout the day. It's the reason for early morning, it's the reason that men get early morning erections. So it's important, the time of day that it's measured is important. It should always be measured with these pituitary hormones because it tells us where the problem is. And in general recommendation is for at least 2 levels to be measured. Sometimes we can catch a man when he's ill or under a lot of stress, and the testosterone level may be low, and we check 2 weeks later, it's totally normal. So we don't want to base our diagnosis on just one level. Talk a little bit more about what's considered to be normal, what's considered to be low or hypogonadal. 300 nanograms per deciliter, the units don't matter, but that's a good level at which a lot of symptoms of low testosterone start to appear. So it's a reasonable cutoff point. It's not perfect. We'll talk about that a little more later as well. So this is the reason that it's important to get evaluated and not just have someone start you on testosterone when you haven't had a level checked. This is a pituitary tumor that would certainly cause low testosterone because it's taking up the entire pituitary. So this is a surgical disease. It's obviously pretty rare, but something we don't want to miss, and very important that we don't ignore the control mechanism for testosterone. It's also possible to have a primary testicular cause that could have other ramifications that we'd want to know about. So again, evaluation, very important. What about just age-related decline in testosterone? It turns out that men's testosterone levels gradually decline as they age, and it's less dramatic than in women with the menopause. There's a more dramatic decline in estradiol levels around the time of the menopause. In men, it turns out that everyone's testosterone level gradually goes down as you advance in age into your 40s through the 80s, and these are some studies demonstrating that, especially with free testosterone, so the unbound testosterone in your blood that actually is responsible for testosterone action, clearly goes down over time. So the issue becomes, how do we define low testosterone in men as they age? And it's been a very difficult issue that's still not completely solved. We have had some recent studies looking at, published just over the past couple of years, looking at how men with clearly low testosterone, meaning 2 levels less than 300, with symptoms of hypogonadism, so at least one specific symptom and some less specific symptoms, respond to testosterone replacement. This is just another demonstration of the age-related decline that occurs in testosterone. But all by way of saying, what should the normal range be, and when do we think we should initiate treatment? And what are the benefits and risks of testosterone replacement in older men? The definition for older in Marin is a little different than it is in other places. I have several 90 and 100-year-olds in my practice, so not easy to define. But these trials that I was mentioning that were recently published looked at a large number of men in multiple centers throughout the country, about 700 men, all of whom were over age 65 and had clearly low testosterone with symptoms. And there was clearly a benefit for libido and increased sexual activity. Men had more sexual activity, they were more satisfied with their sexual activity, and they rated their libido higher. They also had improved bone density and estimated bone strength, again, very important, and it does look like this is a reason for accelerated bone loss in men that should be treated. Also, anemia got better, even if it was anemia that had been, so low red blood cell count, even if it was determined to be of another cause, it often improved with testosterone replacement. And then mood and some measures of walking and strength improved. For example, the 6-minute walk test, some men improved the amount or the distance they could walk during that period of time. So I think there are clear benefits in appropriately selected patients who have had other quote-unquote organic causes ruled out, because those are things that we can fix with in other ways besides with just using testosterone replacement. So for appropriately selected patients, clearly appropriate as long as there's an appropriate discussion of risks as well. This is just a demonstration of the improvement in bone density in this large clinical trial that I was talking about. Not only did the spine bone density, shown here, improve significantly, but the estimated strength of the spine improved dramatically during this year of testosterone treatment. So clearly a benefit. We don't know whether it decreases the risk of fractures at this point. That requires a longer study with more people.
That looks dramatic.
It's dramatic. Now this is volumetric. So this is 3D bone density rather than what we usually use for. We usually use DEXA, which is a 2D measurement of bone density. This is actually CT bone density. So the percentage change is always higher with this type of measurement. It does look dramatic, but it's not quite as dramatic as it looks. I thought this was an interesting study. Kind of dovetails with what Dr. Keefe and Bennett were talking about with lifestyle change. This is a very small study of just 14 men in Italy who started out with testosterone levels mostly below 300. Some had baseline levels a little bit above that. And they basically gave these 14 men a diet, hypocaloric diet, so lower calorie diet, not very low calorie, but a calorie deficit of 200 to 300 calories per day, meaning that they were eating 200 to 300 calories less than they needed to maintain their weight, and an exercise program. And the goal was 10% weight loss. 12 of them succeeded in this, and for the other 2 were not successful, but you can see that many of them had really significant rise in their testosterone levels. These were several measurements at each, so these are average measurements. There are a couple people down here who didn't change at all. Maybe these are people who had other causes of low testosterone that needed further evaluation, but it's pretty fascinating that 10% weight loss, which is not a huge amount, can have this kind of effect on testosterone levels. So the risks of testosterone replacement, and this is something that maybe we can go into more depth in the question and answer session, but prostate tissue is clearly a testosterone responsive tissue, so you can get prostate growth in response to testosterone replacement, and some of that depends on how high we get the levels. You can also have growth of a pre-existing prostate cancer. Increased red blood cell counts can be a problem. If they get too high, there can be sludging in the blood vessels, and that can lead to increased clotting risk. Breast tenderness and growth of the breast can occur. That's especially because men convert some testosterone into estrogen, and if the estrogen to testosterone ratio is too high, you can get gynecomastia. Fertility suppression is mainly an issue for younger men. Venous blood clots in the veins seem to be more of an issue in people with a clotting problem, a known clotting problem or a family history of a clotting problem, but it is a possible side effect. And cardiovascular risk is an area of a lot of controversy and is still sort of uncertain, but I do think that in men with pre-existing cardiovascular disease, we have to be very careful about how we start testosterone, how high we get the levels. Interested to hear Dr. Keefe's take on that, but I'm always very careful about this in clinic if someone has known significant cardiovascular disease. Worsening sleep apnea is also a possible issue with low testosterone, with testosterone replacement, and it seems to happen primarily in men with severe sleep apnea who are untreated. So treated sleep apnea is not an issue. That's really it. Thank you very much, and take questions.